Good afternoon, and welcome to HSDM for another one of our Global and Community Health seminars. We are very pleased today to welcome Dr. Subra. Dr. Subra is former member of Parliament in the Malaysian House of Representatives from 2004 to 2018. Prior to that, he was appointed as the Parliamentary Secretary for the Ministry of Housing and Local Government. Subsequently, he was appointed as Minister of Human Resources of Malaysia from 2008 to 13, and eventually was Minister of Health from 2013 to 2018. Under the Human Resources Ministry, Dr. Subra was instrumental in the introduction of minimum wage in Malaysia and brought forward many reforms to protect workers in Malaysia. As health minister, he led a major move to bring out transformations in the health system, particularly aimed at addressing issues of non-communicable diseases and sustainability of health financing. He has served as Vice President of the World Health Organization and Chairman of the Western Pacific Regional Office of the World Health Organization. He has spoken in many international forums, in particular the World Economic Forum, World Health Assembly, Regional Health Assemblies, Harvard Ministerial Discussion Seminars, and at the Eats Foundation forums, University of Singapore. He is a medical doctor, by training, who graduated from the National University of Singapore and is a consultant dermatologist who was trained in the United Kingdom and Ireland. He is a fellow of the Royal College of Physicians in Ireland, fellow of the Academy of Medicine in Malaysia, and honorary fellow of the Royal Australian College of General Practitioners. He is married to Dr. Umarani, a clinical biochemist in Malaysia, and has 3 children. So, Dr. Subra, welcome to HSDM. You've had an illustrious career covering many issues of policy. And in our seminar series, we love hearing about how individuals like yourself plotted out their career paths. Starting out as a physician, did you ever imagine that you would find yourself as Minister of Health, as Vice President at the World Health Organization? What twists and turns in your career led you to some of these positions?
Thank you, Jane. Thank you for that wonderful introduction. And also I'd like to thank both the Howard Chan School of Public Health and the Dental School for inviting me for this webinar. And so what you said, just to give a big background, as you have introduced me just now, because my life, of course, started off as a medical doctor, like most of us here. And over the period of time, some doctors do get in community work. Everybody wants to get involved in public work to some degree or other, and everybody does it. In certain ways, I probably did more than the others. So where probably public service became quite a dominant portion of my life, then invariably dragged me into the realms of politics. So as you have seen that I was not an appointed minister, I'm an elected parliament member. That means I had to stand for elections and win elections and then become a parliament member, and then from that become a minister. In contrast to other communities in which ministers of health are appointed by the presidents or the prime ministers, and they can pick up anybody from the professional sector or others. But our country, like the British system, we follow the Westminster type of parliamentary democracy, where most of those who become members of the cabinet or the legislature, they actually, the executive come from parliament. That means they essentially, in which case, I mean, you are actually also a politician and a minister. So I went through that process. That's not an easy process. Being a doctor is actually a simpler process.
Oh my goodness.
going into politics and standing for elections and sort of going through the throes of politics, which is a totally different ball game, for which you are not really well trained in medical school, because medical school gives you certain traits which makes you better politician. At least that's how I like to claim to be. The human connectivity, the feeling of empathy, which is supposed to be inherent in those of us who are involved in the medical field, and our ability to connect with people, understand problems. I mean, as people who practice in the health field, whether we have the medical doctors in the medical side or dental doctors, we meet very often. We meet complete strangers, and within 10 minutes or 15 minutes or 20 minutes, they are with us in the room. We develop a relationship. And by the time they leave the room, there is already a bonding, a relationship which is built during that short period of time. And that repeated exposure to that kind of environment gives you a skill set to be able to interact with people much better. So by which I'm saying that doctors could become good politicians if they do try to, because of this basic thing where you can actually have the empathy and the ability to connect in a short period of time and develop the bond within a short period, and that allows you to. So along that I came, and then I went through the phases which you are very well actually introduced me, and I held 2 ministerial posts in the Malaysian cabinet from 2008 to 2018. That's for a good 10 years. And in 2 very important portfolios, both dealing with humans directly. One is the human resource, and the other was health, which has got direct connectivity. So, and during those phases, of course, the main impetus was to form changes which are important in nature. I mean, how to make policy changes which can have long-lasting impact of community as a whole. So, as you introduced just now, Jane, while being the Minister of Human Resource, the significant change which I probably brought into the Malaysian workers' life was to introduce minimum wage. We never had minimum wage. There were, of course, difference of opinions and views among past leaders in our government as to the value of minimum wage. Of course, from which angle which they look from, there was always this fear which was embedded that minimum wage might increase the cost of doing business and reduce the competitiveness which you might have with your other neighboring countries in which wages might be lower. And we as a country attract a lot of foreign direct investment. For example, many of the semiconductor industries from the United States have plants in Malaysia where they make semiconductor chips. And at one time, we were one of the world's largest exporter of semiconductor chips to be used in computers and many other devices which require these semiconductor chips. And one of the reasons why companies like that shift over there is on the perception that you can have lower wages to do the business in those countries compared to countries in which wages are higher. So wage has always been a consideration among investors in trying to choose countries according to the type of activity which they are doing. So when they are doing activities which are labor intensive, which requires lots of people, they tend to choose countries in which the wage costs are low, whereas countries in which wages are high, either they cannot fit into that competition because or they go into industries which involve more technology and less people, where wages can be higher. So when countries choose to be labor intensive, then one of the things they try to do is to keep wages competitive. And that was something which was happening in the region. So everybody was looking for that FDI, the foreign direct investment, and hoping industries can come. But to fight against that was quite tough, putting the case against it and saying that the people's welfare and the ability to get a decent wage in line with cost of living and so that they can give it was initially a problem. But eventually we went to go through it. It was a major battle between the employers, the economic consideration within the government itself. We went through the initial process was tough, because whenever you introduce something totally new, you have to go through the challenges which comes with that. Having gone through, of course, now it has been there. I think we legislated that in somewhere in 2012. Now it's nearly 9 years of existence, and it has undergone multiple revisions, and people have started to live with it. Industry has learned to live with it. So the fear of the unknown was gone, and at least that process is giving. And that actually made a major impact on the lives of the poor, because we actually raised some of their wages by nearly 50%. So when you raise wages by about 50% immediately, that time, that impact which it had in eradication of poverty and increasing a better livelihood for people was tremendous. So, and that is now accepted. Then when I came to the Ministry of Human Resources, Health, again, we were looking how we have a good health system. Maybe before I go up on the reasons why we felt that we wanted to transform it, like what you said, Jane, that some of you also involved in some of the studies which we did to cause some changes, health transformations. But by and large, we have got a good health system. I mean, to start off with, good health system, because Malaysia has a public health system which more or less follows the National Health Service kind of British UK system,
Okay.
where it is funded by general taxation by the government, and then the government provides public health service at all levels, from the primary, secondary, tertiary care, and of course health promotion and public health, all incorporated. The government takes that responsibility, and to a great extent, that public health services are provided can be considered free of charge. There is more than 90%, 95% subsidy into that to the service. For example, if you take a dental services concern, the costing range for anything from an ordinary scaling down to even things like extraction will range only from 1 Malaysian ringgit to 5 ringgit. 5 ringgit is about maybe $1 US, $1 US. So you can actually come to a public health clinic in Malaysia, a primary health center, and have a dental extraction for less than $1 US. I mean, that is a kind
Wow.
of service which we provide. So when you do provide that kind of service, so that is the first point. So when you do that kind of service and you don't charge people, and then the whole thing has to come from the funding from the government through general taxation, then of course that has got challenges in its long-term sustainability. So we spend about 4.4% of our GDP on total health expenditure. To just give you a perception of that, the United States spends about 18% of GDP on health. So, and of course, the US GDP is large. So compared to that, we spend total is about 4.4%, out of which the government probably spends about 2.4%, and the public sector about private sector 2.2 or 2.4%. So when we spent about that amount of funding, and then you want to provide an wide array of services, ranging from primary care, secondary care, and tertiary care. And nowadays, particularly with the advent of technology, and with the advent of innovation and newer medications and drugs, then whether we can sustain this is a problem, because for example, in my class in Harvard Chan last week, we did a case study on the management of the treatment of a condition called hepatitis C, and in Malaysia, which is a public health problem in our country, where we probably have our population is about 33 million total population. We have nearly about 450,000 to 500,000 people probably have hepatitis C. And the discussion last week in our class was the availability of a drug for this condition, which was initially difficult to treat. And when non-treated, hepatitis C leads to hepatitis, inflammation of the liver. It's a viral infection, leads to inflammation of the liver, then it can lead to cirrhosis of the liver, and eventually can lead to liver cancer. So at one time, there was no effective treatments for it. Then this drug came, which provided a 95% cure rate with 12 weeks of treatment. The problem was that drug was so expensive, incredibly expensive. So we were discussing the challenges of this, how an innovation comes into being. And in US, a 12-week cost for that drug, which was agreed by the US payer mechanisms to pay for the treatment, was $84,000 for a 12-week treatment. And of course, the company which produced this medication decided to price this drug according to the income level of the country. So Malaysia, being a middle income level country, we were priced at $12,000 US. Even at $12,000 US, which translates into about 48,000 Malaysian ringgit, and that will be the total annual income of a family. And our argument, which was not possible, and of course at the end of the day we did something very drastic to make it affordable. But I was telling the class that how in a health system, and eventually brought it down to about $100 US. So I was trying to bring the comparison between this $84,000 and $100 US for a similar kind of treatment, and to see how health systems vary, and how we need to actually identify a good health system. So in my view, of course, the US is spending too much for the outcomes of health, which can be achieved at a much more lower cost. So I mean, that's not the area which we're going to discuss today, but that so along that argument, so we wanted to see how we can make innovations like that affordable at a cost which is also within what we can make which is within the reach of our health system. Mm-hmm. So in that, the main thing we know that we need to spend more on healthcare. This 4.4% is probably just not enough to meet up the current challenges. So we probably need to spend more. So we thought we probably need to spend a little 6 to 7% of our GDP on healthcare.
I think that's a really fascinating example. There are so many innovations in healthcare that can save lives and enable people to have a much richer life from a health and social perspective, quality of life perspective. I'm really fascinated by the relationship between oral health, non-communicable diseases, preventive care, and how we might achieve downstream savings. We have some work underway here at Harvard School of Dental Medicine in a couple of different countries, as well as here in the US, where we're working very hard to try to integrate preventive and primary care services at the community health worker level, at the community clinic level, and also into chronic disease management. And we've done some research that shows that good oral care can help prevent infection in the mouth, inflammation in the body, can promote management of disease, non-communicable diseases like hypertension, diabetes, respiratory disease. And so I'm just wondering, as you think about some of these systems issues, a system that's covered by taxation instead of largely by private insurance like we are in the US, do you have to get into conversations about rationing or prioritizing care? Do you have more of an emphasis on primary and preventive care, where arguments like the ones we tried to put forward around including oral care, where it may have been siloed previously, if there's an argument for downstream benefits, both in terms of health and cost? Have you used arguments like that, and how do they play into systems thinking in a national health service?
Right, true. Our health system, if I just tell you how our structure works, we work at 3 levels. One is the primary care, the secondary care, and tertiary care. And we have got a very extensive network of primary care clinics, both in the public service and in the private service, private sector. If I take a typical good primary care clinic in the public service, within that primary care clinic, there will be one, of course, provision of primary health care provides. And number 2 is an embedded preventive and public health element within the primary care system itself. And most of our dental services also sit in the same place with the primary care setup. So our dental services are part of the overall, we call it a health clinic. And in that health clinic has got primary medical care services, maternal and child care services. Then it has got public health services like immunization, and then preventive health services, all integrated into this primary care setup. So, for example, like what you're saying, when an antenatal mother comes for a maternal checkup, she gets a complete medical checkup, which also includes the level of a dental oral health care. So, and then the dental system, which is within the clinic, will be involved in a seamless manner to be able to take care, to provide oral health care advice to the antenatal mother, and of course take care of status. So that's one example. So likewise, but while the systems are there, but over the years, when you introduced me, you said one of the reforms was, which I was trying to address, was the epidemic of non-communicable diseases. And unfortunately, and that is a major, before COVID came, that was a major epidemic which we were having, and a very high rate of obesity, hypertension, diabetes, ischemic heart diseases, and lifestyle-related diseases. So in that sense, of course, like what you have said, that oral health care probably can probably be a potent trigger of the inflammatory processes which probably led to these problems, the NCDs, and how treatment of that can have a positive impact in reducing NCDs. And this is something which is known to our public health specialists, including the medical and dental public health specialists. And so we have got, in fact, our access to good dental care to address this issue is quite extensive and accessible and free. But the only problem, of course, when anything is free, sometimes for some kind of specialized kind of treatments you want, you probably had a waiting time list. You might wait, and people might not want to wait. So if they don't want to wait, we also got a private health service which runs parallel to the public. They go there, they pay their money, and they do. But those who cannot afford, in fact, vast majority of people come for their basic services into the public health system because it's good. It's highly affordable, and the people who treat there are actually fairly well trained. So and in integrating it into that, let me see whether I can get the screen share. Right. Can I share the screen?
Yeah, I can see it. Thank you.
You can, right? I'm just going to slideshow. Okay.
So it sounds like you have a nicely integrated system, you know, a true public health system that is addressing primary care concerns for the population. And you probably are well aware that our system is very fragmented here in the US, and there's a lot of discussion right now about expansion of Medicare services for older adults and expansion of the exchange services, Medicaid expansion, because of so many gaps in care and inequities in our system, so many people falling through.
So if you see here, our dental services are divided into, divided into three categories. One is for the epidemiological, the research and professional development part. The other is the health delivery service part, where we have, and the other is, of course, on the manpower, human development, standardization, and quality determination part. So through this organized, and this entire structure actually exists within the Ministry of Health itself. And from that, through that, we provide the dental services in an integrated manner, where community outreach programs and then community-based oral healthcare programs, along with primary care dentistry and specialist care dentistry, is provided for within the government health system. And some of these are based in the primary healthcare clinics itself, like periodontal services, and some of the restorative services, whereas some are within hospital systems like oral surgery and pediatric dentistry and special needs dentistry. They are in the hospital, but all of them work in a seamless fashion, under the same structure, under the same leadership. So referral between them is quite common, but anybody who wants to see periodontist within our system is to go first to the primary care dentist, who will determine whether they need to see a periodontist, and upon referral they go to go. So sometimes that is where probably the snag will be there because the number of periodontists might not be sufficient, so the ability to refer them early might not be there, but the system for that kind of services already exists. So within this kind of broad structure, we provide all the elements of dental care, like which you said, other than the community-based programs which are preventive in nature. For example, one big program which we run, which probably has the biggest impact, particularly at least in the development of awareness of oral care and to reduction in the prevalence of caries, is about school dental program. Nearly, I think now the figures will be something 85% or so of all schools in Malaysia, the primary schools and the secondary schools, have got school dental services. In some of them, the dental nurse actually sits in the school itself, if the school is big enough. And then, and through a phase of time, a period of time from from teaching the younger kids how to brush teeth properly, till the older ones how to on examination for caries teeth, education on diet,
Mhm.
education of non-smoking through the dental program. Of course, non-smoking has got a major program. We also got a non-smoking within the dental program. So within the dental program, there's a no smoking program. The nurses, if they identify their signs of a school child smoking, they will detect it, pick it up, and then advise and continue on. So there is not only the provision of services, but we get a widespread community outreach program with a lot of innovation. For example, there's a one program called Dental Icons, where within a community, the dental workers will identify people who were excellent oral health care. And that person will be the icon of the community, somebody the community can identify with, and then becomes the icon. And then through that identification, try to create more icons. I mean, there's no limit to the number of icons which can come out of the community. So more and more can come out, so long as you meet after them. Means that you have no caries teeth, you got no feeling, you got your periodontal status is fine, and all that. So this this kind of innovation goes on continuously to get the community be aware of this. And of course,
So the icons go to schools, clinics, different, okay.
different programs. Icons at different levels. At one stage, we had icons who are artists and sportsmen and all that. That is at the higher level. Then you have icons at the grassroots level, who are members of their own community, maybe it's icons in the school or icons in the villages from which they come from. And also, then they have all this. I remember I opened one program in which they were trying to introduce a kind of Japanese puppet show to exemplify dental practices.
Oh, wow.
I mean, this is something which would have been attractive to the preschool kids, for example.
Right.
Because while the school program showed significant improvement and reduction of caries, the challenge was in the preschool kids who were not part of the program, because they come from the home environment. To expose them so that they also can actually get the better benefits of this. So what I'm trying to say is, on the one hand, while we have programs which are structured and which are providing services at all levels, primary, secondary, tertiary care, until people get root canal treatment for $1 US and all this kind of stuff. So, but we also have this community-based. So we got the fluoridation program, and we have areas in which the water we think is not fluoridated. This weekly sodium fluoride rinsing with the school kids do for 40 times a year to reduce the under supervision, to make sure that you can reduce in those kind of communities which are not in areas in which the water is generally fluoridated.
Okay.
So to identify different problems and different issues, and having specific interventions, and this is a continuous thing which we goes. I think if I look, so the point which you're raising is to increase this awareness and to create the linkage that because, and this is particularly true in the adults, because despite the fact that we have made availability of dental services universal and also affordable, the unfortunate thing, the utilization of dental services in Malaysia is still low. It's about 13.2%, which according to global figures is still considerably low. And this utilization through the programs in school and all, it's fine. But in the older generation, the existing older generation, who have grown with the culture of losing teeth is part of growing up or growing old, and you are able to live with it, and then particularly the culture accepts it. So when you want to reduce, look here, we want to make sure that the number of people with 20 teeth at the age of 60 to 70 should be at least 30 to 40%, which we are not achieving now, which is a target. But then that is actually due to the awareness in the community. Look here, this state could have been prevented. I mean, there's
Absolutely.
no reason why at the age of 60 you should be losing teeth. You know, is something which you could have prevented. And if you started this 10 years ago, 15 years ago, going for your regular checkups, your scalings, and brushing your teeth and simple mechanisms, this is where the gap lies. This is where the gap lies. And this is the struggle which I think our public health system. And now with this notion that previously was losing a teeth is just losing a teeth. Now having a bad poor oral hygiene means you might become a diabetic, or there might increase incidence of ischemic heart disease. This connection is something which has to be verbalized, which has to be exposed, because the reaction to this might be different from the previous reaction.
Right.
The previous reaction was, hey, so what? I can live with a denture. So what? I can live with no teeth. Nobody appears. If within a place where 20 people, all 20 don't have teeth, it's fine. It's the norm. It's not that normal. And you will find that in a lot of rural communities, in many countries, in the less developed countries, that is quite common. So if that is more than that, his message has to be connected. But there's something new which we, as probably in the last few years, and this message has to go. And I suppose if that messaging is right, there can be a significant change in attitude, leading to greater utilization of dental services. Not so much only at losing teeth, but for the whole general health status. And I think that is important. Yeah.
Right, absolutely. And as you were alluding to earlier, in terms of access to healthy food, social interactions, employability, etc., all of those become really important reasons. I'm wondering, for our students who are listening, what are ways that you might imagine that students who are interested in issues of public health messaging, understanding how to affect policy change, what paths forward could you see for students who are interested in achieving some of the policy changes that you have, short of going into office, perhaps? What are there types of research? Are there types of organizations they could be working with? What would your suggestions be?
Right. Okay. This is a good question, but in the sense, one, of course, the policymakers, the legislators and the executives who make decisions which affect the rest of the life, and those who want these changes to be made, and how do you connect them, right? I think it's not easy task. Even I think 2 days ago I was having lunch with Bob Belden on his work. Mainly, he was telling me of how he was advisor to the Senate on health matters, and how he was trying to address the Senate Committee on Health, and they are only interested. Look here, I've got a constituency. You tell me how it affects the constituency, and how they are going to think about me. And that is the same thing everywhere, right?
Right.
Same thing everywhere. For example, when I used to work with some of those in Harvard who were trying to help us, I used to tell them, look here, whatever we do, we cannot lose the election. So our primary endpoint is see, what you do should be something which is it's also jives with the political path. Because if it doesn't jive with the political path, then you are not going to get it across, because it's difficult. Then I mean that also affects. For example, health financing is a major problem in Malaysia, because we have been trying to transform health financing, and as I already told you, we are providing everything free. if we were to change or something to free and to tell people, look, hey, why don't you pay some money for it? It's not going to be easy.
Yeah.
I wanted to increase the cost of, I mean, it was to some extent, it was being abused by people to coming and doing things because it's free. Youth using the services. Some of them probably they work in another country, and then they want to have their feelings done, everything. They fly off to Malaysia to get it done free of charge in our clinics, and then go off.
Oh, wow.
Because that because they know the country in which they're working is going to be 5 or 10 or 100 times more expensive than what they're going to do it here. So because of this, we need to charge
medical tourism,
because
right.
anything which is free sometimes is not valued, so you need to actually charge people. But any attempt to increase it even by a small amount will always stop at the last minute, because politicians have fear of the political backlash of that, even the small increase which it might cause. So you need to have political courage, first of all, to implement this. So now coming back to your question, how can those people who are help connect with policymakers or policies? So this you see, scientific concepts will only remain theories and will not become policies until scientific concepts enter into the realdom of real politics. So that connectivity is important. So what those who are interested can do is to educate politicians. First of all, you have to educate the legislators and the policy makers on the value of the knowledge which we have, or knowledge which you have. For example, now you're saying the studies of which saying that, look here, if you don't treat dental conditions properly, you probably will have a higher incidence of, assuming ischemic heart disease, right? And then we get the connection between the economic connections of these, the loss of productivity which is going to come because of that. And then you're going to equate the finances which are related to that. And once you do that and you get the whole thing together and convince the politician, look here, it's not as simple as what you think, doing a scaling in a dental clinic, but it is something which is much more important. It is something which is going to reduce the risk of this person probably getting a heart disease later on, which if he does, is going to cost you so many thousands of dollars, and this probably is just only tens of dollars or hundreds of dollars. And there's a major, you're actually investing into something which is going to be a major saver, and this connection is important for politicians. So, and I think that knowledge has to be developed by whoever wants to cause the change, and then has to be communicated to the politicians so that it is politically impactful for them to say, look here, right, let us invest this amount of money into this, because the long-term benefits of this is going to be huge and is going to translate to so much saving for the national coffers. And once that conversation is right, then of course your ideas will become policies. So you need to work with that. Either you work as an individual, or you work with an academic institution, or you're working in activist groups which are causing these changes. This conversation is very, very important. This conversation to translate this idea, this information which we have, so that information actually goes into a policy, because the politicians find that it's politically feasible and politically needed, because, and so this is important.
So if I might just ask you a question along those lines, I have heard at times from colleagues who work in other sectors of healthcare that that oral health is not a priority for policymakers. And for those of us who believe it should be a priority because it has so much influence on what happens all over the body. I mean, your food goes in through your mouth, you speak through your mouth. We, as you and I have spoken throughout this conversation, there are so many non-communicable diseases and others that are influenced by what happens in your mouth. How do we put forward the message? I mean, do we talk about oral health in the context of overall health? Do we very specifically relate it to maternal child health? Do we specifically relate it to non-communicable diseases? Do we attack on all fronts? What would your recommendation be for those of us who are working in different countries where oral health continues to be siloed, and we'd like to see it better integrated into the systems like it is in Malaysia?
Right. At the end of the day is how the allocation of the health expenditure fundings comes into. So different countries in their different states of development allocate health expenditure according to what is important for them at that particular point in time. So in countries in which malaria is a major problem, they probably invest more money to malaria control than others. And likewise, so in that context, even in Malaysia, I think we spend about 2.5 to 3% of our total health expenditure on oral health care. Probably some countries I know spend about 4 to 5% of total health expenditure on oral health care. So, but that shortage is something which is common to all aspects of healthcare in Malaysia. So every field will tell you that we are underfunded. So it's not only oral healthcare is underfunded.
Of course.
But having said that, I think the awareness, it is a two-way process, Jane. Two-way process. One is the community, and the other is the policymaker. So one way to change is to impress upon the community for the need of this change. So once the policymakers realize that this is what the community wants and this is what the community needs, then they respond to it. They respond to it. So while you're targeting your work on the policymaker, you also need to target the work on the community itself to impress upon the policymakers to cause a change. And that will get the message across. For example, if there are sections of community which are denied this, and they can be convinced that, look, this is your right, you should have, and not having it is actually exposing you to all these things, you might not get a good job, your functionality becomes lesser, you cannot enjoy good food, you can't chew it properly, and then your quality of life goes down, and then worse still now, you might get other diseases of the inflammatory cascade, and all these are there, and you are not having this access to this treatment. And that voice of the community, I think, is something which policymakers cannot run away from. At the end of the day, they determine their fate too. Right?
Excellent. Yes, right on.
Yeah.
So I'd like to see if anyone listening to our conversation has any questions to put forward to Dr. Subra at this time. We have just a couple of minutes left for questions. Perhaps not. Okay.
I see 2 questions in the chat box.
Oh, here they come. Okay. How can we move toward reimbursement for outcomes versus fee for services and bridge the gap between medicine and dentistry?
Health funding in many parts of the world is shifting from the payment for services to outcome-based health funding systems. I mean, even in our kind of system, we were trying to shift towards that. So now, of course, ours is service orientated. I mean, the dental division of our ministry will say, this is the number of clinics which we have, this is the number of people who visit us and the fillings we do, we need so much money, and we give them the money. And within that, for 1 year, they organize themselves and do it. But it's not related to funding based on, number of scalings you did, or number of fillings you did, or number of teeth which were saved. So that is a evolving field in the in health economics, where we shift the funding mechanism from one which is based on provision of service to one which is based on outcome of services.
Mhm.
I think that's a progressive move. And to answer your question is, it can be done. You see, to do that, it's anything which is quantifiable. First of all, you must have systems to quantify it. Where numbers can be quantified, outcomes have to be quantified. That is where the professionals have to come. And then once the outcomes and the numbers are quantified and quantified to a level that can be used and as a kind of method to actually determine payment. So then the shift from a service-based reimbursement system to outcome-based reimbursement system will go, and probably that might give greater impacts, because at the end of the day, we are looking at outcomes, not just the number of visits, for example.
Right, right.
Right.
And so we've had a couple of questions that have come in related to organization. One question asks, what role do organized dentistry and medicine play in the Malaysian system? And a related question is whether there have been consumer advocacy groups in Malaysia for oral health, and did they play any role in how the national oral health programs were shaped?
Certainly. Yeah, definitely. We have, I can specifically tell you the names of specific consumer groups or groups which focus on oral health, but they do have a big role. There are a lot of programs which the ministry does with some of them in combination. So they're not averse to each other. So there is good, and I think that is very important. Like in any other part or aspect of medical practice, to have civil societies being advocates of certain outcomes and certain changes. And so we have our share of those groups, and the interaction with the medical community is cordial, and it's open. And in fact, we have community programs which the ministry itself, the oral health division, does with different groups. So like at one time, there was this program trying to reach out. Ours is a multicultural society, multiracial, multireligious, and each religious institution has got its own attraction for its group of people. So and it's very often it's a site in which people come and get together. So there was a program which actually started working, the ministry plus religious institutions. They went there, they did the screening, the examination, and with the people, either around the churches, the mosques, or the temples, or and sit with them and go through. So likewise, there is no shortage. And then we had a program with college kids on telling them that you can have a smart, sweet smile and work towards it, and a program which was targeted to them. So so many such programs which going on. So the question on organized dentistry and organized medicine, I don't know what it implies, but as far as provision of our services is concerned, ours is a structured mechanism. Like as I told you, oral health services is part of the Ministry of Health, which also produces the other services. They are under the same structure. The overall boss is the same minister and same director general who determines the policies. So in that sense, both are interlinked very closely. They don't work in silos. So when I was a minister, I probably was on the 13th floor. My oral health division was probably in the 10th floor. So we have to meet each other every other time, and every week when I have my ministerial meeting, the oral health head sits along with it. So they become part and parcel of the overall health. They're not isolated. They know what's happening in the medical field. They will know what's happening in the health financing aspect. They will know what's happening in the NCD challenges. They also know what's happening in the pharmaceutical division where they're having problems. So they are part of the overall system. So in our structure, that silo thing is not there because we are part of an integrated system. So I don't know how other countries and other practices are.
Okay, so we have two questions to conclude. One is whether there are integrated health records that include medical and dental information for patients. Is all information accessible in one unified record? And the second question is, has the COVID-19 pandemic brought a new awareness of public health issues, and has it reduced any silos that might have existed?
Yeah, of course, COVID has globally has raised the importance of health in the government. You see, in any government, health is part of multiple things: education, defense, finance, economy, agriculture, environment, water, this and all that. What health COVID has said, look here, if health goes, everything suffers, and that the message has been the biggest message. What happened in the Jane, right? When COVID was there, we had to close schools, shops had to close, people lost jobs, economic productivity went down, everything suffered. There was not one single sector didn't suffer. So this awareness in this drastic way for everybody to realize is something which COVID brought. So I think if any government is not woken up to this, I mean, they are sleeping, actually, If any government is not woken up to this, they are sleeping, because the reality cannot be much more drastic than what has happened, right?
Right.
So the impact has been so direct. It's affected people, people who lost jobs, people whose family got fragmented because somebody died in the family, families in which I know people, sometimes more than one person died. I know families, the father, mother, both died. So the significance of that impact, I think definitely policies, or at least in Malaysia, I think that is aware. I mean, again and again, government say we increase the health budget, we are doing more. And the other thing which is COVID has brought about is about showing that health is not an isolated entity. I mean, this is a thing which we were trying to say, that health in the whole of government approach. The health should be part of agriculture, for example. Health should be part of environment, for example. Health should be part of climate change, for example. Health should be part of education, for example. So this whole of government approach to health, which was previously possibly rhetoric, now has to become a reality. So at one time in my time as a minister, I actually suggested any plan, any project which the government does must have the health quotient index. That means you must subject that project or that program against its health benefits and health consequences before you actually pass the program. So if that kind of wisdom actually permeates into the countries and the governments, then of course the health in all approach will come. So I think that COVID has done us a good job in that, and I hope that we wake up to that reality and do that. The other question is whether health information is available in a single dashboard kind of thing. A lot of health information is available, but unfortunately it's not in an integrated single dashboard. Like oral health information will be available in the oral health sector. The diabetic people will provide a lot of information in that area there. So likewise, but integrating all that into, but nowadays with technology, with a lot of apps which are coming, that everybody is coming, a lot of this information actually goes to the person today, and most of them are tech savvy. We are very Facebook pervaded society. I think nearly every other Malaysian has got a Facebook account, I think. So there is a connectivity amongst people, and through that they get lots of messages. So in those messages, of course, a lot of health information goes through. Sometimes, most often, good messages. Sometimes the problem with social media is wrong messages also can go through.
Right.
So in that sense, we have got this responsibility as healthcare providers to provide that capacity to people to discern between what is right and what is wrong, and what is good and what is bad, and that is also very, very important. So I think the answer to the question is information is available, but not in an integrated single dashboard. And that would be a very, very big dashboard to have all the information available in all aspects of healthcare.
Dr. Subra, I bet we could talk another hour just about health
Right.
information and how to centralize it and make it usable and discern what is solid scientific and what is not solid scientific information. But this has been wonderful. The hour has just absolutely flown right by. It has been so wonderful to have you join us here at HSTM for a very casual yet very enlightening conversation. We thank you so much and look forward to chatting with you again.
Okay, Jane, thank you very much to provide this opportunity to have this conversation. I hope it was beneficial to those who are listening.
Absolutely.
Right.
We'll look forward to speaking with you again soon.
Okay,
You're welcome over at HSTM anytime.
Okay,
Take care.
Bye-bye. Take care.
Bye-bye. Thanks, everyone. Enjoy your day.